Yeah, I want to thank the panel as well, and we're now on to our last session on opportunities for alignment, or really progress on a coordinated public-private strategy for containing respiratory viruses, and as we've talked about today, maybe even more broadly. So we get our two distinguished panelists to come on up for this session. I'll start out with a few introductory comments building on what we've heard about so far. If we started the day talking about some of the challenges that we're facing around taking advantage of the new technologies that have been developed, the new medical countermeasures for our respiratory viral infections. That includes diagnostic tests, includes surveillance technologies, includes therapeutics, and includes vaccines. And I don't want to overly briefly summarize a very rich first panel discussion, but I would say, Peter and David, there were a lot of concerns about the gaps between our unprecedented biomedical technology capabilities and how this fall-winter respiratory virus season is going so far, which seems in many ways similar to challenges that we've had in the past. Can we do better? Our second panel, which focused on this notion of population health benefit considerations and how we design policies to reflect them, tried to address that, with the core challenge being, on the one hand, a lot of these medical technologies can have an important impact on public health benefits, but they're generally, many of them, except for surveillance perhaps, are administered through healthcare systems, which have traditionally been focused on individual, not public health benefits. And conversely, while there's some efforts to improve public health capacities to respond, additional financing mechanisms, et cetera, that's kind of hard to integrate completely around individuals for getting care in their communities and have trusted relationships with healthcare providers and others closer to them. So we did have some discussions about a framework to address that focused on this notion of reducing transmission, something that we heard from our second panel is in many ways measurable. There's epidemiology that's relevant, there's economic analysis and comparative effectiveness analysis that's relevant. It just hasn't systematically perhaps been extended to this level, although we went through plenty of examples of how public health agencies like FDA and CDC and healthcare agencies like CMS and ASPR have gone through these considerations. And we even went to thinking about how you can get from measuring reduction in transmission linked to how to link that to population benefits, both for overall benefits, benefits at the level of decision makers and policy relevant entities that could help change this, whether that's employers in the workplace or those involved with congregate settings, schools, prisons, et cetera, or Medicare with respect to Medicare beneficiaries that they tend to cover for life, and within many within every community in the United States, or Medicaid beneficiaries, commercially insured beneficiaries for the whole family might be covered, not to mention those employer implications again. But then we just went through the policy discussion with the last panel, which laid out, I took away from that, well, there's certainly some possibilities here around CMS reasonable and necessary decisions, around FDA labeling, but maybe not a great evidence infrastructure in place, or maybe other barriers as well. So this session today was not meant to solve all of these issues. It's meant to put forward that we are entering kind of a new era that we experienced in COVID and now coming out of it, in terms of how public health and healthcare might work, and particularly might work together with biomedical innovators. So we're looking forward to end on, I think our second panel declared themselves kind of sanguine, or I took that away. I'm not sure if you all are feeling that way, but maybe we can leave with a little optimism, or at least a better understanding of what the challenges are to make progress from here. So with that, I've covered my summary for this entire last session, so we have a little bit more time to go forward and still end on time, but maybe I could turn to each of you about thoughts on where to go from here and some further discussion. So with that, let me formally introduce Peter Marks, who's the Director of the Center for Biologics Evaluation and Research at the US FDA, obviously deeply involved in all the medical countermeasure development, some of the therapeutics and definitely the vaccines in COVID, and a lot of work with some of the next generation vaccines and other technologies being developed now, which I think are being developed at least in part with an eye towards transmission reduction and fewer side effects, more impact for individuals as well. And then David Boucher, who serves in the immediate office of the Administration for Strategic Preparedness and Response, ASPR, as the Director of Infectious Disease Preparedness and Response, which obviously is right in the midst of all of these issues that we've been discussing. So Peter, maybe we could turn to you for some initial thoughts first.
Yeah, so I think I would divide things into two pieces. And I was listening before online, so before I negotiated the traffic on the way down here. It's getting better, by the way, now. I would divide it into two pieces. There is a medical science aspect of this, and there's a social science aspect of this. Medical science-wise, I think we actually need to aim very high. I actually think that we are more likely to find vaccines that can reduce transmission than we will be to find vaccines that are able to be pan SARS-CoV-2 viruses. In other words, I think it's more likely that we can find a vaccine that will have 95 or 100% effectiveness against some number of strains and potentially stop transmission or reduce it by at least 50 to 75%, which is probably what you would like to see. Even by 50% would not be a bad thing at all. That's pretty good. But I think that's more likely than this kind of goal of trying to find something that's going to cover every last coronavirus that comes up. It's just that biology is too smart, and the nucleic acid rearrangements that this virus can do will mean that we're probably going to still have to have strain updates. But being able to figure out how to make a vaccine that is able to reduce transmission and actually have that measurable effect, I think that is within our reach. And I just want to say that I think in thinking about this public-private partnership, I think there is a clear way of moving forward here, which is the public piece of this is we in government need to help provide the tools, the general tools to help get there, which is things like right now I think that one of the issues that we really lack are good assays for cellular immune response, and we can help from the government perspective in that regard. And then the private piece is that there are a lot of vaccines, very good vaccine developers interested in this space, but having each of them develop their own tool, that's not going to actually help everyone, and it's certainly not going to help a small company that might have a really great vaccine that just doesn't have the wherewithal to spend the millions of dollars that it would take to actually get to the types of assays that are really needed here. We used humoral immune response during the COVID pandemic because it was the tool we had at hand. We went to the toolbox. That was the big hammer at the top. We took it out. We did not try to make a new hammer or search for a ball-peen hammer or something else. We just went with what we had. The other piece of this, though, just to let David say something coherent as opposed to me, is that actually something I didn't hear a lot about today that I'm reflecting on ever more, having just witnessed another anti-vaccine piece come out in a medical journal. If we cannot restore confidence in public health measures like vaccines, talking about transmission is not going to matter. Because if people won't take the vaccines, it doesn't matter if you have a vaccine that can reduce transmission by 50%, because you're going to still have tremendous amounts of virus circulating in the community. It is really a problem. And I just don't know how we're going to get at it. And I wish I could be. I'm more optimistic that we'll find a really good vaccine for reducing transmission than I am that we're going to overcome the crisis in confidence that we have in science right now and getting people to accept this. It really worries me that, probably, I mean, you can argue over it. Was it learning not to put your drinking well where you put your septic system? Was that like the best advance in public health, or was it actually 3 centuries worth of vaccinology that's led to vaccines that actually prevent literally millions of deaths each year? And yet it seems like right now we're at a place where everyone's intent on finding the fault with what are actually truly remarkably safe vaccines. It's not that every vaccine is super safe. We know that. We found plenty of vaccines during the COVID era, some of which were never licensed in the United States because we weren't comfortable with the safety margin. So I just have to, I'm sorry to have to bring that up, but that social science piece is really, you can't talk about reducing transmission without fixing or trying to address that social science piece of it.
Well, it's a very important second set of issues, probably deserves its own.
I'm sorry, I just had to.
But I promise we will come back to that one. But thanks, Peter. Really appreciate those initial comments. David?
Thanks. And, just to get the pessimistic stuff out of the way, I just can't agree more. I mean, I remember, Peter and I were on a lot of calls in January, February, March of 2020, and it was just once we get a vaccine. And, to have gotten vaccines that even perform better than we had hoped at the time. When you do look at current vaccine uptake, it would be great if we can bump that up. However we might be able to tackle that and do that. I just believe it's the best tool. I was going to talk a lot about Project NextGen. We do have vaccines, as Peter mentioned. Codagenics, Castlevac's are 2 of the 3 that we've signed contracts with. They could be the first, among the first to go into phase 2B trials. Under Project NextGen. Both of those are intranasal. Gritstone, taking advantage of, is the 3rd one that we've talked about publicly, taking advantage of a new platform. So through Project NextGen, we expect to push about 4 to 6 new vaccine candidates through phase 2B safety and efficacy. The philosophy there is that we take away some of the uncertainty, and we allow those to transition over to commercial investment, answering some of those questions, which in this crowded field that's a little bit stalled because that investment hasn't been made, which are the most promising, and seeing those carried forward. We're also doing work with monoclonal antibodies primarily. We have a therapeutics arm of Project NextGen, focusing in on the gaps right now. Therapeutics for individuals who are immunocompromised. It's a gap right now in our COVID arsenal. Thinking more long-term monoclonal antibodies that are less susceptible to variants, stay potent longer, and provide lasting protection. And then also in Project NextGen, we have what we call the enabling arm. Those new platforms, self-amplifying mRNA, DNA-delivered therapeutics, manufacturing innovations, all of these things to speed the development of the next ones once we get there. So all that's Project NextGen. The notes that I took sitting over there is that I think we have confidence. The same way we did in early 2020 that we were going to have a vaccine, we have confidence that those products are going to be made. The notes I took today on, the equity, the accessibility of them. We are coming off of 3+ years of federal procurement, federal distribution of COVID countermeasures. I think it's really maybe overly simplistic to say that, okay, we're done and it's going to go to a commercial market and everything's going to be fine. We're seeing some of those differences between the two, where our philosophy was buy more than you need. Get it out to everywhere, as fast as you can so that everybody's within a couple of miles of it. And then deal with, accept the inefficiencies of that system, we are, again, going to buy more than we're going to use, but that's okay because we're emphasizing equitability, or equity in access. And then transitioning over to commercial distribution, where that might not always be the thinking. There was a little bit of uncertainty in demand. It caused a little bit of hesitation. I think we heard from one of the other speakers. Pediatric offices weren't ordering it. They didn't know how much they could store. They didn't know how much they can get rid of. That uncertainty in demand has a chain reaction. It hits the distributors. Are we going to run double shifts so that we can get product out quicker? Do we make that investment? Thankfully, the manufacturing is done long before there, so we don't have supply issues. It's just getting that supply out to where it's needed. So figuring out how we do this. There is a big gap between federal procurement and we are going to supply everything, and just a laissez-faire commercial market has it all, and how we exist in that gray space. There's a little bit I can talk about. I'm not sure if anybody's interested on Paxlovid, over-the-counter tests, to talk about some of the examples on how we try to live in that space and not upset commercial market, but still carry through those values that we have for equity and access over to the commercial distribution.
I would actually like to hear about that, but did you want to add something?
No, I actually, I think one of the things that just goes through my head and it came from the panel that was just, one of the things that happened during COVID, and we did this for like two plus years, is that people got used to getting vaccines really simply. They just showed up anywhere and they didn't worry about paying. I mean, maybe they made you show your insurance card, but I got my COVID vaccines at various places. I got one to try it. I got one at DC Public Health. I got one at CVS. I got one at FDA. You didn't really have to try very hard. No one really cared because no one was worried about who it was paid for. And the administration was, and I think people got used to that. And now that I get calls from relatives. Gosh, I went to the pharmacy. They said I had to get this. People just, any bar that gets put up now, there's very little tolerance now. It's people got used to something over 2 or 3 years that it's hard to get back to the old-fashioned way of doing things.
Okay, well, I'm not sure we want to go back to the old-fashioned way either, since the old-fashioned way did not have any of these technologies.
Right,
So we've got new technologies. That's good. One approach would be to try to go back to sort of the public health emergency approach to dealing with all of these products, which is have a national procurement system, have a national distribution system, have a national delivery system. Doesn't seem like an easy step to get to for more routine integration into things like our seasonal infections or other ongoing public health threats as well. So I guess that's what I'd like to turn to now, and I promise we'll get back to Paxlovid and OTC tests and hopefully trust and misinformation all in 12 minutes or so. So, okay, these products are being made now. What gives us what else can we do to get more confidence that they're going to be used, particularly from the standpoint of population health benefits? And I promise I'll get back to misinformation and individual decisions. One step, as we talked about, was pathways for FDA labeling and support for the needed evidence. Get a label to say this is a product that's beneficial from an individual benefit risk standpoint, but also beneficial from transmission reduction and impacts on people around you and your community and in your place of employment, et cetera, et cetera. Is that as clear as it could be? We talked about, you talked about measures of immune response, but you kind of need measures of
I think if we had a better evidence generation system, it would be easier to get what you want, which is you want population data to say that so that we could put on the label that about a year into things, we realized that the original vaccine cut transmission by 40% or so. It took us that year to get there, so you couldn't put it on the label to begin with because we had to collect the data. And so now with this particular strain, we can collect data, but we probably won't have those data till next year, and there'll be a different strain. So it gets a little tricky. I think until we have a vaccine that we can trust, we'll have a certain efficacy. I mean, if you have a certain efficacy, a vaccine with a certain efficacy and a certain reduction of transmission that you can show that that's happened from year to year, that may make people feel more confident there.
Yeah, and we did hear earlier from Mark Lipsitch about ways in which those kinds of measures have been better validated for some other infectious diseases, and hearing from some of our other panelists, Chip, others, about ways to get better, faster real-world evidence generation systems in place. Let me turn to coverage and payment. So one approach is give ASPR or someone billions and billions of dollars to step in and do a one-time thing for each of these types of products. Another would be to help get our coverage and payment systems to be more about the population health benefits of individual products. And right now, if you look at the manufacturers that you're mentioning, I'm sure they appreciate the help to get to this stage, but if you look at their public quarterly earnings reports and forecasts, they're expecting 15 to 20% COVID vaccine uptake, lower, as we heard about earlier, flu vaccine uptake than usual, limited use of some of the therapeutics, and as a result, their price for these individual products is kind of high. People are going to use them anyway, despite all of these barriers, and there's not really a pathway yet to get to much broader use in our healthcare system. CMS, other payers, as we talked about today, are trying to get to more population-oriented, stronger primary care. Is that something that ASPR and that FDA evidence generation could help? Because it does seem, like you mentioned at the beginning, Peter, that you really need sort of public-private sectors working together, and we have a largely private healthcare system.
Yeah, I mean, it seems to me like one thing that we could probably do right now is have a better public-private campaign in terms of trying to get people to get out to help reduce what could be a wave of issues. I mean, look, here's what will get people to have vaccine uptake. If everyone comes back from Thanksgiving, the new variant is now circulating a fair amount, and suddenly there are a lot of people, there's a spike in hospitalization. We might see, we'll probably see people running to the pharmacy.
Of course, that's not really consistent with a prevention-oriented
No,
approach
that's exactly right. That's the problem, is the whole idea is that everyone should be vaccinated before Thanksgiving dinner, not after. So that's part of the issue here, and I guess part of the issue has not been having we needed collaborations with different communities, because different communities get vaccinated for different reasons. I think we learned that during COVID, the COVID pandemic, and I'm not sure we've kept some of those.
In fact, we saw really a changing dynamic of which populations were behind.
Right.
As we took more steps to connect with individual populations.
Right, exactly. As we connected with I can tell you, even here, just as an example, in D.C., through the efforts largely of physician Reed Tuckson, the black community went from being under-vaccinated to did you get your COVID vaccine? And it became something that they realized that the place to go was like barbershops and community churches to get people vaccinated. So those partnerships actually got people there in that community. It was different in other communities. In some other communities, it was, you want to keep your children healthy. And so you get vaccinated so that you can care for your children. So it's really a matter of having the right part. I think we are going to have to partner, because we're now in this new world of, it's not like we as FDA can say, it's a good thing to get vaccinated. We have to partner with various groups that help then draw in their social media network to get vaccinated.
Yeah, if you look at the surveys, a lot of people do still trust the FDA, but not everybody. Groups that people that are highly trusted throughout a range of demographic, political, other groups. You mentioned Reed Tuckson, that was black physicians against COVID. Is the healthcare providers, and there are just David, back to your point about how we don't seem to have a whole lot of healthcare oriented infrastructure in place to do systematic population-focused efforts, whether it's planning for how much to order from your distributors because you got reliable data on infection rates and public perceptions in your community, need assessments in your community, or it's the delivery system itself having payments that really encourage reaching out to finding individual at-risk individuals who you have a provider relationship with. Can we encourage more of that? Is that part of the ASPR strategy for pulling these countermeasures along?
I think so, and that's a big question. I think we can
Well,
be a part of the solution.
this was Peter's fault. He raised the big questions. So.
Oh, that's okay. Yeah, so I can tell you one of the things that it's during a response. Nobody wants to be in a response. One of the benefits to our organization, I think, was increased communications throughout the government. Obviously, we have pretty good communications in government all the time, but obviously enhanced during a response. But outside of the government, ASPR is not the first agency that comes to mind when you're thinking in response, and a lot of people don't know us. But we did get out there a bit more. Peter and I know this is respiratory, but MPOX, we had weekly webinars where we were talking to public, meeting with ASTO, public health, healthcare providers, Congress, just to try to bring it all together and increase the communication. I think that's something we want to lean into a little bit more. It can be part of the solution. I don't think it's going to be the big answer to your question, but that is definitely something that we've.
I think actually when we start to think about, actually it's like patient-focused drug development applied to vaccinology is what we have to do next, which is that you've got David's group trying to bring the vaccines from this end, and we actually need to figure out from the delivery end and the social media, make the social, it reminds me of when I worked for pharma, how they sometimes they'd have the box for the pill before they actually had the first pill manufactured. Yeah. In this case, I think we need to have the delivery campaign working at the same time. In other words, we should be working, we may be working for towards a vaccine that prevents transmission, and that's the scientific work. At the same time, we should also be starting to work back for how are we going to convince people and what's the campaign we're going to use to get to having 70 to 80 to 90% of the people across the country actually take that vaccine, which is where you really start to see transmission really tamped down and really the best public health effects.
Well, although I think Mark Lipsitch was hoping for below 70% with some of the new technologies that you're developing.
I mean, look, it doesn't. In a closed population, in a prison population, that's probably good enough. But we some of us who actually like to go outside occasionally would like to,
let's talk about that some more. And we've been talking all afternoon about analogs with these medical products that have important population benefits in addition to their individual ones. You just talked about, well, we need an analog to patient-focused drug development. I don't know if that's population-focused drug development or if that's a term that's going to annoy some people, but one of the underlying points that you just made is that people do want to go on and live their lives, and one of the challenges that came up in COVID was either the concern or the reality of mandates or requirements of doing or not doing something, including requirements around vaccines. I think in this environment, for the kinds of things we've talked about today, especially outside terrible public health emergencies, which we hopefully won't happen again for a while, we are talking about voluntary decisions that individuals are going to have to make, which do have consequences for not only themselves, but for others. So are there some ways that we could think about how a population-focused drug development effort would address those concerns? We've had discussions about behavioral economics today. We've had discussions about better information that people can use to understand not only risks at their community level through more accurate data of just what kind of risk are they and their family or people they work with facing, but also what kind of impact these vaccines or other medical countermeasures
Mark,
would have.
you're familiar with part of our problem is we are terrible risk communicators because we have labels that are incredibly cumbersome. They have all sorts of percentages, words that people can't pronounce. I can barely pronounce some of them on a good day.
Does that have anything to do with FDA regulation?
I think it does, maybe. But when you tell someone, well, you know, there's less of a chance from dying from getting a COVID-19 vaccine than getting struck by lightning, and it's actually far less. They actually can get that in a way that they don't have the same problem grasping it as they do when they go to the FDA label. And suddenly, oh, you mean it's that low, as opposed to when they look at the label where it almost seems certain.
But we did
something
hear
that
from
happened.
the last panel, both from the standpoint of FDA statutory authority, it seemed like there was a pathway to allow something like that as a demonstrated population health benefit, and from the standpoint of something that CMS could determine as reasonable and necessary, say, for Medicare coverage. It's just a different way of...
It's a different way of how we do things, right?
Yeah. David?
No, nothing to add to what Peter said.
Okay, well, we are, the clock is flashing red. I'm looking at my watch. I still have 2 minutes to thank everyone who deserves to be thanked for this session, including the two of you. But any final thoughts, or are we going to leave that as a positive enough note for the future?
No, I think the positive enough for the future is that I have no doubt that this crazy swing we're in will probably swing back hopefully into a more positive direction, because I think vaccination ultimately will prove itself to be, you know, the various vaccinations will prove themselves to be highly beneficial. And I think as people see that benefit over time, and as we kind of become a more science-based society again over time, hopefully, this will be, and a more mutually, I mean, part of this is, right, you get vaccinated to assist your fellow person in the society. And as we hopefully get out of our cell phones and back to our dinner table conversations, we'll understand that better.
To end it on a positive note, the technology is there. I mean, you know, we're looking at a lot of technologies through the vaccines, the therapeutics, the enabling tech. It's there. It's advancing
I forgot
rapidly.
to give you a chance to talk about over-the-counter diagnostics.
Totally fine, totally fine. There was a question earlier, when is that going to go away? No time soon. For schools, libraries, FQHCs, all of that. So I'll knock that one out really quick.
Good.
But the tech is there. These things are going to come. We're going to have the tools. I am, like Peter, I'm optimistic the political will come, and we can do education too.
So I want to conclude by thanking our panelists, and I give them, don't get up yet, I do want to give you all a round of applause for a really engaging discussion, a challenging topic to end on. Thank you all very much. And while you're still sitting here, there are a few other things I need to do just to wrap up quickly. Obviously, this is a very important, if very challenging topic. As you said, David, the technology is there and can potentially get even better. And yet, I think we don't, we do want to go back to some better reliance perhaps on accurate information and Americans being able to connect to that information and make their own choices effectively. But I think we want to go forward in some ways that we talked about today in terms of how life sciences, public health, and health care will interact together to really bring together this current separation of public health benefits and individual benefits and risk into more of a technology-enabled population health approach. This is a first step in this whole area of work that we are doing at Duke-Margolis in collaboration with a lot of the people that you heard from today and many others who were thanked in our paper and on our website. So more to come on all of that, and I hope you'll stay tuned with us. And if you have suggestions, ideas, we'd very much like to build on them. I do want for right now, though, to give a special thanks to all of our panelists, including Peter and David, who provided some very thoughtful perspectives on the fall respiratory virus season, but then some much bigger issues related to the health of Americans and people around the world, for that matter, and how medical technology, public health, and healthcare all fit together with regard to that. And not only that, some promising, if challenging, paths forward for clarifying how we could do better, developing better evidence, and supporting policy reforms in terms of regulation, coverage, payment, and federal supports. And then finally, a special thanks to the team at Duke Margolis that put it all together. This is drawing across a lot of our areas of expertise and experience in public health, healthcare, and biomedical innovation. Christina Silcox, Nancy Allen LaPointe, Frank McStay, Bina Boyan Khan, Duri Kim, Hannah Grounke, Mia Williams, Luke DeRocher, Morgan Romine, Hannah Vitello, Sabine Sussman, and Brian Cantor. Brian Cantor, I know a lot of long evenings and weekends from our own interactions. So big group, diverse group to pull this off. I think that's going to be the way it works going forward, but frankly, that's what we need for America's health for the future. Thank you all very much for being with us today.